And welcome to 2020 Pain Care. We have a wonderful panel for you today talking everything pain management. Our moderator, Justin Ferrari, is here with us. Of course, we are starting off with Dr. Ashish Shah from Synergex Med. He's going to be talking about treating acute pain and introduction to the topic of pain management. Then we have Dr. Michael Price with Pledge Medical. He will be talking about PRP with us today. Dr. Hassan Badai from Pacific Pain and Regenerative Medicine will be talking everything stem cells. Dr. Harold Kraft from Laser MD Pain Relief will be talking about no needle pain management treatments. And then, of course, Dr. Paul Chu from Vanguard Interventional Pain Specialists will be talking peripheral nerve and spine cord stimulator therapy. And with that, I'll give it over to Justin to start us off.
All right, thank you everyone for attending this morning. I'm happy to have everyone, and I'm especially pleased to be amongst such great doctors from the Southern California region with a specialization in making everyone's life better and less painful. My goal for today is to make sure that the doctors answer all the questions from our, audience. It is virtual, but nonetheless, we will be taking questions from the audience. So if there's any questions you want to ask the doctor specifically, feel free to jump in. I think we're going to begin with Dr. Shah, but I'm going to ask everyone after Dr. Shah's intro, we'll go around and everyone can take a few minutes to introduce themselves. So Dr. Shah, the floor is yours.
Perfect. Hello, everyone. So I'm Dr. Ashish Shah. And so I'm going to keep this short just so we can get to the panel part of the webinar today. So I'm an anesthesiologist and a pain doctor. So therefore, I get to take care of acute pain in many scenarios, whether it's acute pain right after a surgery or if it's pain right after a car accident. And I really enjoy taking care of acute pain because it's one of the very few fields in medicine where you get to see the results of your work instantaneously or the results in a very short period of time. The patients really truly appreciate the help you get because you can see them getting better and they really appreciate it. And a lot of these times, patients are in excruciating pain and you get to be part of the process to help them. However, taking care of acute pain is not easy. People come in with a variety of symptoms and a variety of levels of pain, and the objective findings might be the same for the two people. Imagine two patients that both have 3 millimeter disc herniations, but the symptoms and the pains are totally different. So we have to work with the patients and find the root cause of their pain. And not every solution works on every patient. Some will require steroids, some will require PRP, and some will just get better with physical therapy and anti-inflammatories, and a very few will require surgery. But I think in pain medicine, we're on the cusp of a truly transformative time. The future of pain medicine is coming right before our eyes. We have now options for patients that were not available 5 to 10 years ago. We are shunning opioids, just like we should, and for good reason. But we also have many options that are not just the typical steroid injections. And don't get me wrong, steroids are wonderful and they can help a lot of people. But now we have many other tools in our toolkit. So today we're going to talk about some of the other tools that we have as pain doctors. And it's PRP, or platelet-rich plasma injections, stem cell injections, no needle epidurals, and spinal cord stimulators. So we have 4 experts who are going to talk to you about each category. So I'll let the panel start with each of their sessions.
Okay, I'm Dr. Michael Price. I'm board certified in orthopedic surgery and regenerative medicine. I practice with Pledge Medical in Southern California. My practice is pretty much all personal injury. So just about everybody I see has been in a motor vehicle accident of some sort. The reason I mention that is almost every patient I see has a spinal injury in addition to some other extremity injury. And with the spinal injuries, the thing I like to talk about with the patient is that if I get a patient who has, for example, neck or back pain, and they have an MRI that shows 2 or 3 discs that may be protruding or herniated, I like to remind the patient, listen, in order for that disc to have gotten protruding or herniated, there had to be an abnormal force at that level of the spine, which means that everything at that level of the spine got injured, not just the disc. So it was the facet joints, the muscles, tendons, the ligaments. And in the vast majority of people that I see, they do not have radiculopathy. So they don't have pain shooting down their arms or legs. It's very localized. Sometimes they'll point to an area that's maybe the size of a silver dollar or a small pancake. And for those people, I'll say, listen, you certainly have a disc issue, and there may come a point in time here where we won't have a interventional pain specialist, like a multiple number of the panelists we have today, to do an epidural where they go inside the spinal canal with a small amount of steroids strategically placed. But if they don't have radiculopathy, what I'll often suggest is, listen, let's try to do some PRP injections to the soft tissues around the spine at that level where you're having your pain. And it's directed exactly to where the pain is. So if they point to a spot on their neck and say, it's just killing me right here, well, that's where the shot goes. So it's pretty easy to do. Some people are even comfortable enough to do it awake in the office. Some people, if it's multiple levels, clearly need to be taken to the operating room and put under some MAC anesthesia just so they're twilighted while you're doing it. But what I've found is the use of PRP to be very helpful for that non-radiating kind of axial back or neck pain that people get, particularly from accidents. And I do want to emphasize, I'm really talking about accidents where there's been some kind of torquing or twisting injury. I'm not really referring to just straight up degenerative conditions where somebody had pain that developed over many years, and because obviously that's not somebody who injured all of those soft tissue structures. So I think the key is to ask, okay, is this a traumatic etiology for the pain, or is this just a long-term degenerative condition? In the long-term degenerative conditions, I'm more apt to immediately turn those over to the interventional pain specialist, because often those will require intraspinal epidurals or even medial branch blocks. But in the traumatic setting, where I know there's been a large soft tissue envelope injury around that disc level that's protruding, that's when I move ahead with the PRP injections. And the reality is those patients tend to get at least some relief, and some get dramatic relief where they don't require going on to further deeper injections. So that's sort of the way I approach the spine when it comes to the use of PRP. When it comes to joint injuries, I've noticed, and I've done PRP since about 2010, somewhere north of 1,500 of them now. And what I've noticed is that PRP works well for joints that have been traumatized, but it works better for non-weight bearing joints like shoulders, elbows, wrists. It seems to work much more dramatically and more long lasting in those joints. It does work in hips, knees, and ankles that are bearing weight, but I will typically tell people, hey, we're going to do the PRP for your knee injury. You'll probably get some relief. We'll keep an eye on it because we may have to repeat that somewhere down the road. Whereas in the upper extremity, which is essentially non-weight bearing, rarely do they have to come back for a repeat PRP injection for those joints. And of course, there are occasionally, certainly some patients who, if they have a partial rotator cuff tear in their shoulder or a meniscus tear in their knee, if I inject them with PRP, occasionally they will not get better. And those are the ones that will go on to require an arthroscopic procedure. Of course, assuming they've gone through therapy and the like. But that's kind of how I approach the use of PRP. And just for a brief comment on what PRP is, we all know that to get PRP, you have the patient sit in a chair, you draw blood from them, I spin it in a centrifuge for about 10 minutes, and then I pull off the plasma. And plasma is full of factors like transforming growth factors that help with the production of collagen, platelet-derived growth factor, which also helps with collagen synthesis, but also epidermal growth factors and vascular endothelial growth factors, which promote angiogenesis. And there's many other things in there, but one of the other properties of PRP is it is definitely not a stem cell treatment, but it does have the ability to signal stem cells that, hey, there's been something occurring at this body part. It almost mimics a new injury. So you get a little bit of heightened awareness from stem cells, and we know that from research showing that they do respond to the injections of PRPs at remote sites in the body. So I'll leave the stem cell discussion to the other panelists. I didn't want to get into that, but I did want to sort of let you know what the components of PRP are that we find most effective. And I thank you for your attention.
Thank you very much, Doctor. That was an excellent presentation. And, I will want to circle back with you and discuss the difference between stem cells and PRP, but I believe, as you stated, Dr. Mobin's going to go through stem cells. So maybe I can call on Dr. Mobin to go next and discuss stem cells, and then, we'll save for the end for you two to discuss the benefits of each.
Okay, thank you. My name is Dr. Badai, but I do love Dr. Mobin too. Give him my best, but
I'm so embarrassed.
no, that's okay. Dr. Mobin's a good friend of mine, but excellent discussion, Dr. Price and Dr. Shaw, and thank you guys for having me on this panel. But let me kind of go back to a little bit about our approach here and what we're trying to do. So my training is in Physiatry, which is I have a board certification in physical medicine and rehabilitation, and in pain medicine as well. So what that entails, basically, I'm in the business of improving quality of life through understanding and diagnosing soft tissue injuries, and essentially we're the specialty that falls under the muscle, the tendon, the ligament, the connective tissue, and how it all can effectively go into like a symphony of collaboration of how the body systems work. Now, what we do in my approach is I'm very clinical based versus my colleagues who are anesthesia based, which they're very procedural based. And we all come to pain management from different schools of thought and philosophies and our training. We basically look at the patient from a multimodal treatment approach when I evaluate a pain patient from a clinical standpoint. So the beautiful thing about pain medicine and the physiatry approach to a patient is that we'll take a complete understanding from a clinical aspect, tie that in with a diagnostic tool aspect, and provide a treatment plan and protocol that is very minimally invasive, multimodal, therapy-based, but medically based at the same time, with a minimal invasive approach. So in our school of thought, we're looking at it as, okay, well, how can we help provide improvement to ADLs, or activities of daily living, and improve functionality and therefore quality of life from an interventional standpoint that is minimally invasive to surgery. What came across was I've been doing regenerative treatments for about 12 years now. I'm pretty comfortable and been kind of leading in the field in that aspect, where it just happens to be that, well, what we know from a normal physiological standpoint, how the body heals itself. Everyone knows this on the panel. The body has, one of the biggest kept secrets in medicine is that the body tends to have the ability to heal itself without any of us doing anything, if the environment and the conditions are there for itself. However, what we're able to do is enhance a physiological process which is the regenerative and pro-inflammatory aspect of what Dr. Price was talking about, PRP, but adding a supraphysiological approach. And that is the that's what the advent of regenerative medicine is and what we've been doing. And really all the combination of these amazing natural occurring growth factors and cells that we normally have studied from a histological standpoint, we are able to maybe add or take a supraphysiological value and add it to an area of injury, such as soft tissue injury, a nerve injury, inflammatory process. And so, I mean, I'll go back to it on a slide deck, but that's kind of our approach from physiatry standpoint. So we'll look at it from a clinical standpoint as well as interventional standpoint, just like my colleagues, like Dr. Shaw and Dr. Price and Dr. Kraft. But that's kind of my side of how we approach pain management.
All right, Dr. Bidet, you're obviously super intelligent doctor, and a lot of the language you're using is going to be above what general attorneys are going to be accustomed to.
Sure.
So in maybe a minute or two, tell us, what does your practice do differently, and when and why should these attorneys advise their clients that they may want to come to your clinic?
Okay. So in my practice, I'm an orthopedic. So how do we provide orthopedic care for personal injury? How do we provide a safe, non-steroidal based treatment without opiates, and to offer treatments that are non-surgical or interventional? So we'll focus on a treatment protocol that is, we will do our standard epidurals. Now, if patients don't have benefit from that, we'll focus on treatments such as amniotic fluid treatment, which means treatment that is that supraphysiological approach, or PRP treatment to the spine. So
I apologize, because you're hitting a really important point, and I want everyone to really make sure they understand this, which is you're starting with the assumption that we know that we need to avoid steroids. I don't think everyone in that understands. So why do we want to avoid steroids?
Fair enough. So steroids we're first of all, let's go to the root of the problem. So if there's nerve root inflammation, or there's a facet joint arthropathy, or facet joint mediated pain, or if the back pain is because of the spine, the pain generators can we control the pain symptoms through understanding a nerve root? So let's try steroid-based treatments. If a steroid-based treatment does not help control pains, then let's try a nerve block treatment that we can do that is traditional as a non-steroid base. Then we can focus on treatments such as a PRP treatment, or a new treatment that's become recognized that is accepted in the insurances and Medicare, which is amniotic fluid treatment. So what we can do is offer advanced state-of-the-art treatment that is now part of our protocol and understood in the Medicare community, actually. So we're able to do these options for patients to, one, maybe avoid or delay surgery, such as joint surgeries or spine surgery. If we can avoid or help reduce their pain and improve their quality of life. So we would start with a traditional customary steroid treatment, but offer interventional non-steroid based treatments and RFAs, which is something that we can burn the nerves, and provide regenerative treatments, which is now becoming more of a staple understanding that we can do that and to help provide quality of life enhancements.
All right, awesome. Thank you so much. And I'm going to follow up in this whole idea of avoiding steroids by going to Dr. Kraft next. And Dr. Kraft, can you tell us about your expertise and what your vision is for the future of medicine as it relates to spinal injuries and things of that nature?
Sure. So thank you for having me. Just my background is I spent 20 years as an anesthesiologist, and then for the past 5 years, the only thing I've done is treat pain with no needle epidurals, which is sort of a marketing name for the medical name is laser photobiomodulation, but I just call it no needle epidurals. And no needle epidurals effectively treat almost all pain, inflammatory pain, by causing the body to release its own anti-inflammatories. Steroids that we've been talking about are external anti-inflammatories, and you can get the body through stem cells, PRP, or no needle epidurals to release its own anti-inflammatories. So it's just a different approach to treat pain, and you can use the no needle epidural both for spinal and peripheral pain.
Is it recognized by traditional health insurers?
So yes, about 80% of my practice is Medicare and PPO, and 20% is accidents and liens.
So if I were to try to explain to my client what a no needle epidural is and how it's distinguished from its needle sibling, how would I explain that to my client?
So the simplest way is no needle epidural is the only treatment where if it's done correctly is actually pleasant. It's a very, typically we use a flashlight. It's a beam about 1 or 2 inches across, and it's a very high intensity laser. Sometimes we touch the skin, sometimes we don't. And we treat a region rather than an epidural, which is pinpoint.
Okay, and I'm going to ask you the same question I asked Dr. Bidet, which is if one of the attorneys here has a patient, a client, and is trying to figure out what type of doctor this patient needs and is working with the patient, and the patient is actively asking the attorney for his opinion, at what point or what should that attorney and client be looking for to know that they need to come to your office?
So the general rule of thumb is to start with the least invasive treatment, chiro PT, and end up in the kind of a waterfall at the most invasive, which is surgery. I think everybody would agree that you start with least invasive, no needle is in the middle, epidural is kind of 2/3 of the way down, standard epidurals. The PRP stem cells involve a needle but are non-steroidal based. So it's a waterfall kind of chiro PT, perhaps no needle or PRP or stem cell, standard epidurals, then surgery as sort of a last resort.
How many of your patients find success with the no needle epidural, and also then what % end up going and getting traditional epidurals in your experience?
So no needle, first I've done the most laser pain treatment, no needle epidurals in the country, about 25,000 treatments. And roughly 2/3 will have some pain relief, almost exactly the same percentage as standard epidurals. In my experience, actually very few end up needing an epidural, probably 10%. Simply because sometimes there's a budget issue. Sometimes patients come to me because they simply are totally freaked out about having a needle. And even though I recommend epidurals, I did epidurals for 20 years, I love them. I tell all my patients that if I need one, I would get one. Not all patients feel like that needle is something that they can grasp or sort of deal with.
Well, I can tell you, I've had 4 lumbar epidurals myself, so I'm no stranger to this treatment and learning about all the up and coming technology. It's amazing to watch. So I guess we're going to transition over to Dr. Chu, which is when all else fails, you call in Dr. Chu to fix everybody's problem. So Dr. Chu, can you jump in and tell us about what your experience is, where your clients seem to be coming from, and why, and how you help them solve the riddle?
Sure. Good morning, everybody. Thank you so much for having me here. I am a board-certified anesthesia and pain management, and I've been doing the personal injury cases for past 4 or 5 years now. And of course, I totally agree with all the panelists. We should start with the least invasive procedures, steroid maybe used in selected cases, and PRPs, stem cells should be the sort of becoming more of the standard of use because of the potential side effect with the that's involved with steroids. But what happened when everything fails? So I have a little short slide presentation for everybody to see, and maybe that way I can go over some of the background of it, and then of course some of the rationales and the science behind what we call peripheral nerve stimulators. That could be another tools to help patient to recover from this injuries. So let me share this with you guys here. So I'm going to go over this. Okay, so I don't need to be preached to the choirs that there's lots of accidents every year. According to the National Highway Traffic Safety Administration, there are about 5 million motor vehicle collisions every year, and about 2 million of injuries. Of course, unfortunately, 30,000 fatalities, and this causes pain as well. The lower back pain is the most common musculoskeletal disability condition for an adult that have the prevalence of about 84%. And of course, that individual younger than 45-year-old, that's the #1 most common cause of disability. And we define chronic back pain as a chronic pain syndrome that has lasted for more than 12 weeks or 3 months. This way past beyond its normal healing period. So mechanical lower back pain is generally as a result from some acute traumatic event, but also can cause by just repetitive cumulative trauma. And the severity varies from just simple bending, twisting, up to perhaps a motor vehicle collision or a fall, slip and fall. As you can see, here's a model of the spine, and the spine is composed of, the lumbar spine is of 5 vertebrae. The vertebrae is composed of the bony structure, the ligaments, the joint capsule, muscles, and of course all the nerve innervations. And it has to serve 2 purposes. One is it has to be very strong to protect our spinal cord, all the nerve roots, but at the same time has to be flexible, mobile, so that we can do our routine range of motion. And the pathophysiology of this, the pain is very complex and also multifaceted, because any of those elements, the bones, the ligaments, the nerves, the disc, can all be part of it, of the cause of this pain. And of course, between 70 to 80% of the back pain is really the true cause is not known, it's unknown. And most of the pain is again has a mixture of nociceptive, which is more the soft tissue type of injury, and neuropathic, which is a nerve irritation. So the management consists of, obviously, the goal is to control the pain, control the inflammation, restore the range of function and the soft tissue flexibility, improve the muscular strength, endurance, trying to retrain some the coordination of the spine, and improve the general cardiovascular conditions, of course, maintain the exercise program. And as we all agree, surgical intervention should be the last resort in treatment of the lower back pain. We can divide the pain into separate categories. The one that has radicular component and non-radicular component. So when we say radicular component, meaning the limbs are involved, pain shooting down the arms or legs, and that with numbness, tingling, sometimes weakness. And someone just stay within the trunk, the axial part of it. And based on that, there are different treatments. We always recommend to start with the interdisciplinary rehabilitation. So physiotherapies, chiropractic therapies, and maybe some over-the-counter or prescription strength anti-inflammatories to begin with. But when the pain is predominantly axial, which means it stays in the trunk, fascial injection has to be very helpful. If that proves to be successful but non-lasting, we proceed with the medium branch block and continue with the radiofrequency rhizotomy, and sometimes epidural injection just for axial pain. When there's more of the radicular component, so the pain going down the arms or legs, then epidural steroid injections are probably initially what is being done. Sometimes surgery, if there's some structural compression, such as stenosis, slippage of the spine, then that may be discussed. And lastly, if those things are done and that still not helpful. Traditionally, surgery probably is the next step of treatment. So the idea to treat patients as early as we can is to avoid developing into chronic pain. And the way it develops into chronic pain is basically there's an inciting factor. The nerves are sending a signal to the brain to say that they're injured, there's pain, and that injury somehow become unbalanced and start to send in more where it's supposed to, and causes the brain to change its behavior, and now sensing even normal sensations or something minimal sensation to become very painful. And the idea is break that cycle to prevent that first from developing and change all that. So traditionally, we said medication, physiotherapy. If that doesn't work, injections. If that doesn't work, ablations. That doesn't work, of course, surgery. And if surgery didn't work, we consider spinal cord stimulator implant to help. But what if the patient had done all those? So you tried all the medication, tried all the injections, even some surgery, or some patient, unfortunately, they're not surgical candidate, or some patient that you can't really find any significant pathology, a disc bulge of 1 millimeter. Everything else seems to be normal. Or someone just flat out said, you know, I don't want to have surgery because I heard so many terrible things about surgery, what to do. So for those patients, I think now we have other options. We think that about 80% of the lower back pain patient suffers from a muscle that's highlighted here, that's called the multifidus muscles. They have atrophy on those things. And that and as we said, 70–80% of those patients with lower back pain are of unknown, non-specific cause. Then it's possible that that this back pain, the non-specific cause is because of the centralization of it, because of the continuous sending the signal to the brain. And what if we can help to improve the atrophy of those multifidus muscles, reduce the centralization, and therefore improve the pain? The way how these multifidus muscles work is that if there is a soft tissue injury that's not neural, they can cause decreased signal desensitization to those to the muscles, and that creates instability to the joint. And the facet joint itself, of course, due to overload, can continue to create additional damage, and then there's a vicious cycle that goes on to perpetuate into the chronic pain. So the idea is that if we can improve the signals, prevent sensitization, avoid the maladaptive cortical changes, therefore we can stop the chronic pain, and of course restore those normal physical activities. And the new algorithm usually that we try to do is that the first 3 months of therapy, conservative treatment. If that doesn't work, then we start talking about interventional pain treatments, including epidural injections and whatnot. And somewhere along that, before the surgery, will be the neuromodulation, which is try to modulate the change of, prevent the changes. And there's also quite a bit of supporting literatures about the use of peripheral nerve stimulator now for the lower back pain. Basically, if we stimulate those nerves for about a month, once we remove the temporary peripheral nerves, the stimulators, the relief continues to up to a year, sometimes up to 2 years in the most recent studies. And that is what we can offer to our patients. And most patients are very happy to have other options, because what if when we talk about radiation, radiofrequency ablation, which does not spare the muscle, because by ablating the nerve, the multifidus muscles will continue to atrophy, and that could continue to perpetuate some of the maladaptive changes, versus the conventional neuromodulator, where it doesn't spare those the muscles, but requires a big surgery. It's an implant of a device that maybe patient is averse to. So that peripheral nerve stimulator seems to cover both of the issues much more favorably. And if you ask about 452 patients about the options of a permanent stimulator implant, a permanent peripheral nerve stimulator implant, a temporary peripheral nerve stimulator implant, or a radiofrequency therapy, probably majority of it will like to stay with the radiofrequency and the temporary peripheral nerve stimulator implant. But if you talk more about the outcome of it, most people at the end will prefer the peripheral nerve stimulator implant versus any of the other options. So the new algorithm that we think that is going to help the patient is between the ablation and the injection stands the peripheral nerve stimulator, so that we can control some of those pain that is not necessarily amenable to those early injections and does not require immediate ablation of those nerves, because we want to preserve the neural structure, we want to preserve the muscular in the spine to maintain the stability of the spine. So, but peripheral nerve stimulator is not only limited to the back, anything, chronic shoulder pain, knee pain, chest wall pain due to rib fractures, foot pain, ankle pain, basically any identifiable nerve pain that has no obvious treatable options. This could be a very viable solution for their pain conditions. So having said that, then of course we do all those above, and just this is another one of our tools to be able to help the patient when everything else fails and the patient is not necessarily ready or want to have surgery. And then return the floor to Justin.
All right, Dr. Chu. So I'm going to ask you the same question I've asked everybody else, which is, at what point, if our client is actively asking for the attorney's advice, right, at what point should we advise them to see you? At what point do we give them your information and say, look, you know, if you want another opinion, I've met this doctor, I've sat in on a session of this doctor speaking and teaching us. Obviously, you sound very informed and very well researched. When do we send a patient to you?
Usually, our practice sees patients towards the middle of their initial chiropractic treatment. But we've seen patients from all spectrum. The patient who just had an accident 2 days ago versus the patient who has been through the different cares for years. So I think usually after about 12 weeks of a conservative treatment, if the pain is still not satisfactory, or slightly before 12 weeks time, it's a good time for us to evaluate the patient.
Okay. And does your office do any of the injections that some of these offices do?
Absolutely. We provide all those injections that the panelists provide. So epidural injections, facet injections, whether with steroid, non-steroid, or PRP, all those things is part of our tools that we offer to patients.
Okay. So then I guess, kind of going back to the intro question I had for you is, what do you see failing and where do you see the success in the stimulators, and what different options do we have in terms of stimulators?
Well, I think the stimulator is certainly not for everybody. Just walk through the door and say, this is for you. A stimulator is just one of the tools that we have in order to help patient better. And it's just solving a puzzle. We try to figure out where the cause of the pain is, and we try to target that. And unfortunately, as we mentioned, about 70–80% of the causes are unspecific. Then we can always use this. And most of the time, the stimulator therapy, because we don't have a crystal ball to see what's going to happen, there's a trial period. So this is not basically a non-committal type of a therapy that you try it for a certain period of time before you say it helped or not. That will commit to a long-term therapy. So for patient, peripheral nerve stimulator is very non-invasive or minimal invasive and well tolerated. So I will say that anybody who has not had a good relief from facet joint injection, median branch block, or had those but do not want to have any ablation done, the rhizotomy, stimulator is definitely a very good option for those people.
And what is the procedure like?
procedures is very simple. Could be done under fluoroscopic guidance, which is X-ray, or just ultrasound guidance. Basically, for the lower back, we identified that the spinous process, and then just two wires inserted directly perpendicular to the spine, and that's it. And then connect to a little external receiver that will send stimulation impulse to the patient. So they'll try the therapy.
And then what's removal like?
Removal is just like taking off a piece of IV or something. So if you had a injection before they've done IV for you, I just remove the IV. It's very simple. It's nothing. No. It's done in the office. Very painless, basically.
Okay.
Pain-free.
And how long do you expect that these modulars should be installed in the people?
So if we talk about the temporary peripheral nerve stimulators, it's a 60-day therapy. If a patient after 60 days do not find that's very helpful, but upon removal, they find that the pain is returning, then we can discuss a permanent implant. And that permanent implant will remain in the body for the duration of the battery, which may last anywhere between 7 years to 15 years. And now, actually, the newer technology now that's not required to implant the battery, and then just lasts for as long as the device, the patient's lifespan, basically.
It also looks like we have a question for Dr. Badai. This was asked a little bit ago. They ask if you can briefly explain in stem cell procedures from prepaid stored umbilical stem cell in bank to its usage. So how does that work?
So very interesting, right? So in the concept of using a banked stored stem cell versus a new fresh cord blood that is commercially from tissue options, we find that it's usable if someone has their own stem cells and they want to use it in our facility. However, I mean, essentially, getting it from some entities that currently have stem cells available, it's really, there's a specific, good manufacturing process, and the regulations are very tight approached in terms of, companies that we use locally here in United States, California, and we basically will use, these, like, for example, a third party tissue bank like Invitrix Biologics as an example, and they can bring product to the clinic and to the offices and use those. But basically, it's simply available versus using someone's own stored cord blood, which we can use, but it might be more expensive, from the storative process. So we'll partner up with a third party company and provide stem cells, which are completely safe allogenic sources, and do targeted tissue treatments. Stem cells, but right now what's become very popular is the acellular allogenic amniotic tissue treatments, which is becoming more and more recognized as a insurance approved care for our patients with soft tissue inflammation and pain. So been using a lot of that, and it's been very cost effective. And we're able to do that. But these are treatments that are very safe, has been studied, we've been doing treatments for years, and it's been effective in getting patients inflammation and pain under control. Now, I don't want to bring out my slide deck and talk about the process, but I mean, if everyone's interested, I have my slide deck that I can introduce to the panel, and you guys can see it. But it's pretty comprehensive on the mechanism of how stem cells work. But we can save that for another time. But,
all right, so I have two major questions. So I'm going to start with the first one. I kind of open it up to the panel. What success have we seen using PRP or stem cell being injected into either the epidural space or the facets?
I specifically don't use it for the epidural space. I have had fantastic responses for the facet joint capsule inflammation. I use it primarily in the facet joint arthritic changes. So someone comes to me with axial neck or lower back pain, I've realized the added advantage of going in with a nerve block first and then finding that the diagnosis of facet-related pain has been established through that injection, then we'll go in aggressively with amniotic fluid or stem cell or PRP for facet joint-mediated pain, and then I'll follow that up with an RFA and get a really good response out of that. So predominantly, it's been really effective in pain and functional improvement and medication reduction for the facet-related aspect of it. I don't know what.
Dr. Price, any opinions?
Yeah, I would say, and I wanted to reference Dr. Chu's lecture. He brought up a very important point that I cannot overemphasize, which is the multifidus muscle directly correlates with the health of the spine and pain levels. So, in other words, anything you can do to plump up or strengthen the multifidus or the other paraspinal muscles around it is going to decrease back pain. And that's predominantly why I would say, I think it's pretty well considered that the standard of care is, if you're going to use steroid, that's certainly fine for intraspinal in the epidural space, and really that's the standard of care. But anything outside of the spinal canal, where the multifidus or the other paraspinals are located, if you can get PRP or some form of stem cells, whether it be the patient's own cells or banked cells or stimulator, that's very, very critical in helping restore the strength of those small muscles, because they have a huge effect on the patient's pain levels. So that's kind of my general comment about inside the spine and then outside the spine with steroids.
So what's your opinion on cortisone injections?
Well, I think they certainly have a place. For epidurals, the cortisone or steroid is still standard of care. But when you talk about the facet joints, you can now use PRP or steroid, and that's still considered, either one of those is okay. But once you get outside into the muscle, which is, as we referenced earlier, is also injured during these accidents, then you really need to start considering using something that stimulates that muscle to maintain its strength and maybe even improve strength, being PRP, stem cells, or neurostimulation.
So would you advise for trigger point injections or some alternative?
Well, I still think trigger point injections have their place. Trigger points tend to be a little bit more superficial than we're talking about. That's kind of more the superficial muscle layers. But when you get down to those muscles right around the spine, those are a little bit deeper. So that would usually require some kind of imaging, like ultrasound or the use of C-arm, whereas trigger point injections, generally you don't necessarily have to have any imaging for that.
Okay. Dr. Shah, do you have any comments on that? You're on mute, Dr. Shah.
Yeah, no. So I totally agree. I think, in the spinal cord, the epidurals, cortisone is still the standard of care, like Dr. Price said. And, what we've seen is PRP in the facet joint, just like the other doctors have been saying, have been really, beneficial. And then as you go superficial, it's, like trigger points or in the muscles, the PRP really helps with those situations. And, one thing you asked, everyone is, when does an attorney decide to send a patient to a pain doctor? And I think, as everyone has said, we see all spectrums of pain. So I think, in our practice, we tend to be very academic. So me and my partner both come from academic backgrounds. So we like to spend time with the patients and educate them on what's going on and what's the right thing to do and why. So even if you send them right after the accident, 2 days after the accident, we'll tell them, hey, usually typically these accidents or pain goes away in 4 to 6 weeks. That's why we have this period called conservative treatment. And we want you to go to a chiropractor or physical therapist and take the anti-inflammatories. So we can be that process of educating the patient and, you know, taking care of where do they need to be in their care, getting the MRIs and why they need MRIs. So we tend to be very academic in our practice where, you know, me and my partner both started this practice a few months back, and we both work for other, you know, practices that fill up their schedule with 30 to 50 or sometimes 60 patients a day, and they don't get the patient has no idea what's going on. So I think our practice, we want to be very academic as possible and spend the time and educate the patient. So in the spectrum, send them whenever you feel like it's appropriate, because we can help them guide from the beginning. Or if it's, you know, after chiropractic care has failed, they've seen a surgeon and they're scared of the surgery, we can still help them and educate them in that process. And
Yeah,
Justin, do we have any more last comments for the panel before we wrap this up?
I have one that I've seen many young attorneys grapple with, and it's kind of twofold. Number one is, how can the client be prepared in their time visiting you to give you a full rundown of their complaints so you can properly diagnose their issue?
I mean, I think I just want to piggyback on what Dr. Shah was saying. I think it's absolutely right that spend quality time with the patient to, educate them early on, and maybe the panel and the attorneys to know that they can come see, you know, medical first and then kind of quarterback the entire process. And as they go to conservative treatments and therapy and then chiro and surgery, just kind of handhold them and let them know that this is like this. To answer your question, I think having them have established, maybe get their medical questionnaire ahead of time so they kind of understand what the kind of things we'll be looking for ahead of time to kind of organize their thoughts as we see them in the office setting. You know, ahead of time, maybe have our intake forms in front of them. The advantages of communicating with the case managers and everyone in the office about how we kind of see patients and what to look out for, and how to kind of prime the patient or the client before they come to our office, what to, know what the doctors are going to be asking or looking for ahead of time is kind of really important, I think.
Awesome. I want to thank everyone so much for your time. This has been a very educational panel. There's so much wisdom amongst all of you, and tens of years of experience, if not close to 100 years of experience between this panel. It's been awesome, and it's been my pleasure hosting.
Thank you all. Thank you, Justin, for moderating for us and all of our wonderful panelists. And if you want any of the contact information or CVs or presentations shown today, go ahead and email events.dm, D as in Dan, M as in Mark, at injuryinstitute.com. We'll be able to send those over to you too. Yeah.
Thank you.
Thank you so much. Have a good one. Take care.
Have a good
Bye.
day. Go on. Bye.